Still missing a few more students.
Good afternoon, Professor Marvel.
Hi, Sharice. How are you? Doing okay? Good. Okay. Yeah, missing 3 students.
You're not letting me in. What is going on?
All righty. We are recording. Okay. All righty. How is everyone? Welcome to week 9. Getting close. A couple things I'd like to do today. I want to go over some recent announcements I just sent to you, particularly the roadmap for the rest of the term. And then I want to go through the concepts from this week: human abuse and violence and cultural influences in nursing, and talk a little bit about how culture affects your daily life and your work life. So we'll talk about that. And then I want to go in and have a look at the exam 3 study guide and start talking about some of the concepts and plugging in the information. Remember, concept learning, which is what this class is about, and your other classes as well. Concept learning is taking the knowledge you already have and building upon it. So we'll talk a little bit about the study guide. And then this week, if you can, there's 3 live exam reviews. I sent that updated calendar to you a couple days ago, I think. So you have that. So if you could try and attend one of those, that'd be great. You'll get all the recordings to it. All the recordings from each of us. I'm doing mine this afternoon. Let's have a look and see who's doing. Go into our announcements. Everybody see my screen?
Yeah.
Okay, thanks. I know mine is this afternoon. Professor Kershaw's is Sunday. Anybody taking a look at this? Here they are. So Professor Kershaw's is Sunday at 6. Mine's this afternoon at 3. And then Professor Ford, she's doing hers tomorrow at 10 o'clock Eastern. So those are the 3 reviews. Okay. The other announcement I want to go through to see if anybody had any questions was the roadmap. Was this helpful to go through the next 4 weeks? In one announcement, I know it's a lot of information. Okay. Anybody have any questions about this? So this is a busy week, as we talked about at the very beginning of the term. After week 8, it gets super busy. Weeks 9, 10, and 11 are real busy for you guys. So this week we have a lot of things due. Okay, you have a NCLEX, your 3rd set of NCLEX questions is due Sunday. You have a case study, a HESI case study, domestic violence and cultural competency. That's also due on Sunday. excuse me. And then you have your HESI prep assignment. It's also due on Sunday. I've already had several students turn in their HESI preps, so I appreciate that coming in early. So those three are due this week. And then the fourth item, if you can, is try to attend a live exam review. And we just went over those days and times. So that's this week. And then next week, you have your exam. Right, you guys will be taking the same thing as exam 1 and 2. You'll be taking on Tuesday. Post the exam grades on Saturday, as we've done before, since we have a late Friday night class. And then next week, you also have your vulnerable populations assignment due. All right, so you get your exam, no more quizzes, get your exam, and then your vulnerable populations. Okay. Also next week, our HESI reviews, 3 different HESI reviews, which are on that schedule that I just pulled up for exam 3. They're right below exam 3. So I know it's an exam week for you, but you also have the opportunity to attend 3 different HESI, specifically HESI reviews. Okay, so that's in week 10. Okay. And then once we get to week 11, I think I already gave you guys last week the expected HESI dates on campus, right? I gave you guys that last week. We only have this class is Essington and Port St. Lucie. So I gave you guys your intended dates for HESI. Have either your campuses reached out to you for you to start scheduling? Okay. They should be soon. The only thing I can do is provide you days and times. I have nothing to do with the scheduling. I'm just trying to give you a heads up of when they're going to be scheduled. So campuses should be reaching out, or you can reach out to the campuses and go ahead and schedule your HESI for the day and time. Okay. And I would do that by the end of, this is week 9, by the end of this week, I would make sure you're scheduled for your HESI. And then week 11, you'll be taking your HESI. And don't forget, in week 11, you also have your last set of NCLEX questions due. All right, don't forget about that. You can work ahead. It's open. If you want to do that now, I'm okay with you doing that. If you want to do week 9 and week 11 together, just so you don't forget about it in week 11. And then I also attached to this announcement the remediation guidelines. Everybody should see them and know what they are. So tell me about the remediation guidelines. How do you use those? Did anybody open up that document?
What do you mean? How do you use them?
What are they? They're the hours that you need to do, right?
Depending on what grades we get is how many hours we have to do.
That's correct, Sharice. Yes. Yes. So I have attached those so that they haven't changed over the last several terms, but depending upon the score you get, is the number of hours that you need to do remediation. Okay, so I've already attached that for you. I would highly suggest that you start your remediation as soon as you finish your HESI or soon after. I know you're going to have several remediations to do, but remediation is due no later than Monday, December 18th. So that's the Monday of week 12. Okay. And there's no late. You can't turn that in. You can't do that late. It's not done by Monday, the 18th, then you end up with a 0 on your HESI. So I always encourage students to get going early on their remediation so they can get it done. Okay. And then I want to make sure, if you read all the way to the end of this announcement, that your week 11 attendance will be that you took the HESI. So as long as you take the HESI, you get your attendance. Okay. But in week 12, we do have to meet to get your attendance. Okay, so you'll have to come to class week 12 at this time, and it's really short. Okay, we just do end of the term wrap up, maybe talk about the HESI a little bit, your feedback from the HESI, but it's a very short class, maybe 10-15 minutes. That's it. But you do have to show up to get attendance. Okay, and if anybody has attendance issues, you certainly don't want to make this week 12 class put you over that 20% of missing attendance. So keep an eye on that, because if you get to 20%, it's a full letter grade deduction at the end of the term. Okay, so your attendance, your attendance is. If you haven't received any letters or communication from Dean Brown, then you're fine. Some of you may have received a 5% letter, 10%, 15, and I think I have a couple of students at 20. So please show up in week 12 on Tuesday. Okay. Questions? No questions. All righty. Well, let's take a look at our content for this week. This is our last week of content, so we have two more concepts to cover: human abuse and violence, cultural influences of nursing. Okay, so what do we know about human abuse and violence? What kind of, in your preparation for class, in your readings, what kind of human abuse and violence might you come upon in your professional career taking care of clients? Or different domestic abuse? Mm-hmm.
Child abuse.
Elderly abuse.
Yes.
Mm-hmm. Mm-hmm. What else? What about human trafficking? What else? What about family violence?
What?
Suicide, homicide, assault, battery. What else? So we could be taking care of actual victims of abuse, perpetrators of abuse, and people who have witnessed abuse, right? We know with regards to human abuse and violence that it's much more common amongst the vulnerable populations, right? Just like substance abuse is, violence is typically used as a means of exhibiting or regaining control. Okay, when we have victims, we have perpetrators, right? People who become involved in violence are typically have had previous exposure to it, whether they have been a victim or a perpetrator or seen violent acts in their lifetime, right? Abusers, perpetrators were actually often beaten when they were kids, or they witnessed siblings or parents being beaten, right? They typically learn that violence is a way to manage conflict. Okay. What kinds of things, in your opinion, cause our high levels of violence in our communities or in our families? What leads to that?
Drugs and alcohol.
Mm-hmm.
And
Poverty.
history.
Poverty, absolutely. What else?
Maybe someone growing up with abuse in the household, like a learned or, behavior.
Mm-hmm. Mental health, social isolation, high stress levels. Kristen said poverty, maybe unemployment, maybe chronic diseases, right? We all know that we are mandatory reporters. What does that mean? We're mandatory reporters. What does that mean?
We have to report any signs of abuse.
Okay. For which particular populations?
children and elderly, right?
Absolutely. And is that only in your work settings, or can that be anywhere?
Anywhere, but
Anywhere.
mainly,
Pardon me?
I say anywhere, but mainly, well, I guess because I work in there, but anywhere, but mainly work settings.
Hmm. I mean, public places, right? Parks, grocery stores, backyards. We're required to report, right? And then we have a couple of kinds of we have abuse and we have neglect. Physical neglect refers to the essential needs. All right. Food, clothing, shelter, hygiene, and medical care. That's neglect. Okay. So we have physical neglect and we have emotional neglect. Right. So emotional neglect refers to issues with nurturing, acceptance, and caring for essential growth and development or health development. So physical and emotional. We know kids who are exposed to violence, they may be victims or witnesses. They're at much higher risk for mental instability or mental disorders as they get older, right? They're much at higher risk for potential self-harm, for substance abuse, and maybe attempted suicide or completed suicide. Okay. We know that abuse is about power and control, and the violence is about regaining that control. We already talked about that. Family violence, usually the most powerful against the least powerful, right? Family violence is perpetuated in cycles. Children grow up seeing the violence used as a method to control somebody else's behavior, whether it's another parent, whether it's a sibling, whether it's a relative, right? And so as kids, abused kids are much more likely to perpetuate violence or tolerate violence in their own relationships going forward. We talked about poverty being a high predictor. Maybe there's an unplanned pregnancy in the family, unemployment, marital strain, divorce, infidelity, social isolation, lack of social support, lack of resources. Elder abuse is huge. We have to be able to do in our elder assessments, be able to do a physical assessment, emotional assessment, financial assessment. Okay. So elders, excuse me, elders are at risk for any kind of violence, physical, emotional, financial, as well as neglect. What does elder abuse look like? Has anybody ever witnessed elder abuse? What does that look
Yes.
like? What does that look like?
Going into the home and seeing it disheveled, dirty, and them in soiled clothing, marks on their body.
Yep. Some examples. Demeaning the elder, right? Affecting their self-esteem, maybe name calling, scaring them, threatening them that they're not going to take care of them, embarrassing them, destroying their property, maybe preventing them from seeing family or friends. And again, neglect when they're not having their basic needs met. Food, clothing, housing, medical care. And then finally, the fear of abandonment, right? That you're not going to be taking care of them anymore. There's so much elder abuse and so much elder neglect that goes on. Okay. Cultural influences in nursing is the other concept. We talked about cultural competency and cultural knowledge and cultural barriers. We talked about culture the whole term. All right. We know, just in review, we know culture to be, we all are from a different culture. Okay, we all have a set of beliefs, values, assumptions, practices that we pick up through our childhood, right? Every culture is different, right? Every culture can be different with regards to language, time focused, present, past, future oriented, touch, personal space, food preferences, food preparation, body language, maybe perceptions on how healthcare should be provided to them. Cultures are also influenced by family structure, childbearing practices, personal space, eye contact. Right? We know as nurses, we need to approach each client as unique. Right? We need to make our best effort to learn their culture through however you learn: observation, assessment, communication. Right? We need to understand our own cultural beliefs as well and make sure we're not trying to push our culture onto others. Right? What do we do in cultures that have barriers? Let's say there's a language barrier, communication barrier, access to healthcare barrier. We've talked about this before. Trusted community leaders. Remember, when you're in community and public health, everything is about a team approach. Who do you seek out to help in your community with cultural issues? Who do we seek out? Let's say there's an issue with in a particular culture with violence, and you're the one community nurse. Who can you seek out to try and help you?
Community leader,
Pardon me?
a community leader
And
or something.
maybe law enforcement, right? What about if there's issues regarding access to healthcare, language barrier? That you have to be able to seek out trusted community leaders that can help you work with these particular cultures. Okay, trying to maintain an objective, non-judgmental, not punitive approach to these groups. Right? So I want to go through the group and ask a few questions about culture. So I'll just start with where I'm seeing you on my screen, Jakesia. What experiences have you had taking care of different cultures? And what challenges have you had? Jakesia, can you hear me? You're on mute.
Oh,
Yeah.
yes.
Like in your workplace or your community setting. Give me an example of cultures you've worked with or got to know about.
Um, well, we kind of like we had a resident, she only spoke Spanish,
Okay.
so we kind of had to learn, kind of to learn keywords and where, certain words she would repeat, we learned what they meant and stuff like that. And I guess that's the closest we really got into.
Yeah. Did she have family that could help you? Or were you guys on your own?
Yeah, the family would come in and then we did have one Hispanic nurse on the shift, so she would help out a lot. But
Oh, good,
over the
good.
time we just kind of learned like what she would be gesturing at or she would point towards it.
Did you learn a lot about that culture?
Um,
Or preferences or beliefs,
yeah, I would say
values?
preferences. I would say
Yeah.
I'd say preferences maybe.
Yeah. Good. Isabel, what about you? Isabel, are you there? Let's jump to Justice. Justice, what kind of cultural experiences have you had in your community, work life?
I work with geriatric patients.
Okay.
So,
Have you worked with any cultures other than yours?
no, I haven't really. Everybody's kind of been of the same culture.
Really? Okay.
Yeah.
Okay. So then what kinds of things, let's say tomorrow you go to work and you have somebody from a culture that you've never taken care of before. What are you gonna do to become familiar with that culture so that you can adequately care for that client?
If they have family that comes in that
Mhm.
speaks English, I'm going to ask them questions to how to take care
Mhm.
of their family member
Okay. Okay.
and things
Okay.
like that.
All right. Majesty, what about you? You any cultural experiences that you've learned about a different culture and how did that work? Majesty, if you're talking, you're on mute.
I don't know. I really haven't had one.
You haven't had any experiences with any kind of cultures.
Not really.
Okay,
Only
so
Catholic, but that's about it.
what about in your work setting?
Just Catholic. The residents would like watch mass, but that's it.
Okay, do you work with any other, do you have team members that are from different cultures that have different practices?
No,
Okay.
no, not at all.
Okay, so what kinds of things would you do? Let's say that changed tomorrow. What are some helpful tips that you could be doing to learn about different cultures and trying to apply some of their values, beliefs into their healthcare plan? What can you see
Um,
yourself doing?
do research or ask them
Mm-hmm.
about it.
Mm-hmm. Mm-hmm. Be aware of your own beliefs as well.
Right.
Yep. Kimberly, what about you? What experiences do you have?
Well, recently I had a patient, she was currently dying, and her and her husband were Haitian. So
Mm,
every time she would say like, "Oh, I want this," her husband would like override her decision and be like, "No," because she was in a lot of pain and she had morphine. And then
mm.
her husband like, "No, I don't want her to get morphine. She's not getting morphine." And then she wouldn't get because he kind of determined everything.
Wow. So how'd
And
you handle
then
that? How'd the care team handle that?
yeah, we kept saying like, she has prescribed morphine for pain. He's like, no, 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 I don't want her to get morphine. So then of course then she'll say no, like, oh, and then she'll refuse because he said no. So then we kind of and then she didn't really like the food. So he'll cook and bring her food.
Oh, interesting. So she
Yeah.
wasn't able to eat the facility food.
She didn't like it. She'll always refuse. So he'll
Uh-huh.
come for lunch and he'll cook her like lunch
Mhm.
and like leave some dinner because he wouldn't be there for dinner. So then she'll eat that. That was the only way she would eat.
Did she end up, so you got a couple issues going on there. You had a cultural issue and really kind of an ethical issue, right? With pain management. Did she end up getting pain? Did she end up getting the morphine?
No, she had passed away
Mm,
a few days after.
wow.
You could tell she
Um,
was in a lot of pain just by
yeah.
like the physical, like her facial expressions and like the grunting.
Mhm. I mean, that for the rest of the class, that's a really good example um, of cultural barriers, right? I
I have
mean,
one
okay,
that I just found.
I'm getting to you.
I found. Oh,
Go ahead.
okay. I'm
No,
sorry.
go ahead. Go ahead. Go, Kristen. Go.
No, because I didn't learn about it until I was starting nursing school. But
Okay.
when I worked at a doctor's office, I think it was a Muslim couple, and I used to get pissed off that he would always do the talking for her, like she in person on the phone, like it was always him. He would call and make the appointment. He did the talking for her, and I didn't understand that because I didn't even ask any questions when I worked there. I just kind of went with the flow. But then once I started nursing school, I found out that you talk to the husband, not the wife.
So you weren't thinking about cultural differences, cultural preferences. You kind of,
I thought it was a control thing, honestly,
yeah,
at that time.
you made
Yeah,
assumptions,
I did.
right?
Mhm.
You made assumptions versus understanding the culture. Yeah, that's a great example. That's what we talk about early on in culture is trying to be as informed as you can, right? As educated and informed about all the different cultures that you're going to be working with, whether it's a coworker, whether it's a client, whether it's a family member, whether it's a relative, whether it's somebody in your community. We have an extremely diverse population. And so Kristen just gives an excellent example of before and after. Before she was making the judgments, making the assumptions. And as she began to learn about this particular culture, things started to make sense, right? Whether it's right or wrong, that's the culture. Whether you believe it's right or wrong, doesn't matter, right? Thanks. That's good. That's good. Brianna, tell me about a cultural experience for you.
Um, well, when a Jewish person passed away at my job,
Okay.
their family don't believe that they should pass away alone, so his wife stayed with him every day until he passed away.
Okay.
And she also wanted him to be like laid on the floor with his feet pointing towards the door, something like that. But they wasn't allowed to do that. So she just wanted them to open the window because she said that's the way his soul can get out instead of being trapped in the hospital.
Interesting.
Yeah.
Interesting. And so, excuse me, one of the things I picked up from Brianna's story is even though we try and incorporate as much of values and beliefs and practices, there was actually something that you couldn't accommodate, right?
Right.
And
Because they
so,
were saying it was unsafe for him to be on the floor.
right. So, yeah, excellent, excellent. Jacqueline, what about you?
I am going to be honest. I have not experienced any different cultures besides mine. I am Haitian. I just know that in this culture, Haitian men feel like they're superior, but in my opinion, they are not. So any other culture I have not experienced yet. And as I get more advanced into this field, I will experience other cultures and know
Yeah.
what to do and like how they go about things. But right now I am completely clueless.
Well, well, in a way, but also in a way, you're bringing in your own culture, your Haitian culture, right? So you have the opportunity to teach others, right? Your coworkers, right? About different aspects of your culture they may not be familiar with, right?
Yes, ma'am.
Yeah, yeah. Isabel, are you back? You keep coming in and out. Shante, go ahead. Tell me about what you've experienced.
Um, right now, I currently take care of a little boy, their wrist plan,
A what?
and basically their house, Thailand. So
Oh, okay.
their household is a lot of their family is in one house. The
Yeah.
grandparents, the aunts, the cousins, everybody's in there, and the mom has to take care of everybody for the most part.
Interesting.
That's all I've experienced.
And then how do you incorporate your cultural values and beliefs into your care of their little boy? I mean, is everybody around? Everybody's around watching
Yeah,
what you do.
for the
Yeah.
most part. Mhm.
Have you learned
So
a lot about their culture?
I'm learning. I just started with them, so I'm learning as I'm going.
Wow, that's awesome. That's awesome. Charisse, What do you have for cultural experiences? All right, Sharice isn't there. Let's jump back to Isabel. Isabel, hey, um, tell me,
Hi.
do you know what we're talking about?
No.
Okay. We're talking about cultural experiences you have had, whether it's a patient, a coworker, somebody in your family. What have you done to improve your cultural competency?
Mm. Can I have a minute to think about it?
Of course. Sharice, go ahead. Give us an experience.
Well, I've been a patient care tech for like 20 years.
Okay.
I'm originally from New York, so I've experienced so many different cultures living in New York. You know, the Pakistan, the Indian from India. I mean, Russian. I mean, I've experienced a lot of different
Yeah,
ones.
absolutely.
I mean, I could give you an experience of my own. My family is my dad is Indian. He is from Trinidad, and we had a death in the family. And with us, we had a death in the family on Friday. So with
Oh,
the
I'm sorry.
deaths and thank you. With the deaths in our family, when it's like the Indians, so like on the seventh night, we do we do for 7 nights straight. We do dinners like wakes every night.
Uh-huh.
That's what we do. And then like the last night is like a certain night we do prayers and certain things like that. But I do remember an instance I had in the hospital working for Mother Baby, an Indian couple. You know, we had to go in the room several times at night because what happened was they would have the grandmother, the father, and the mother in the room, of course. The mother's on the bed. The father is on his cot, but the grandmother is on the floor on like a flat mat with the baby. And I had to tell them, no, I'm sorry, but we cannot have the baby on the floor. But in those kind of cultures, they're used to like the grandmother coming in and taking over for the
Yep.
mother.
Absolutely.
So
Absolutely.
when I talked to the grandmother, the father was like, well, this is, he was upset, but I was like, but we can't have a baby on the floor. Like the baby has to go back in the crib, cannot be on the floor. So it was a little issue for a little while, but it was okay. And then
So
I think
another
I had an issue with an African couple at one point because the husband wouldn't talk to me and I had to talk to the wife. But like whenever I came in the room and the mother would be like really tired and trying to get stuff done, and he would just be over there laying down, not really helping, but in their culture, certain things the mother just has to get up and do no matter what.
interesting.
So I guess and I would be
Yeah.
perturbed because I'd be like, what is he doing here? If he's not gonna help you, and I know you're tired, you just had a C-section, but can't say anything. You have to be like this. You have to
Well,
go and just do your job.
yes, but if it's a cultural belief on their part, like the Indian baby on the floor with the grandmother. I mean, there are certain things you can accommodate and certain things you can't. But the whole purpose of being how we move towards cultural competence is understanding different cultures, right?
Yeah, I've learned to be unbiased. Like I
I
just
bet.
know that when it comes to a certain thing and you just go in and you ask them certain things and you help them with it. But if it's something that's against hospital policy,
Exactly.
that's when I step in.
Exactly.
Besides hospital policy, I
Right.
don't step in and I have to keep my bias to myself.
Absolutely. Well, and that's one of the things we talk about is one of the very first things of establishing cultural competency is checking your own feelings, right? Checking your own feelings, checking your own beliefs, checking your own biases if they're there, checking your own prejudices, right?
Mhm.
I mean, it's critical. Isabel, back to you. Give us an example.
Every year for my family celebrates Hanukkah. So every year for Hanukkah, we go to Miami to my aunt and uncle's house. And then the youngest usually lights the first candle,
Oh,
and everyone brings different types of kosher foods.
mhm,
And my aunt usually says a different Hebrew prayer every year.
mhm, mhm.
So that's nice.
Yeah, yeah. Now, have you had any experience in your work setting with working with different cultures and having to accommodate certain beliefs and
Mm,
practices?
I mean, I work in a restaurant and I do takeout, so my encounters with people are pretty fast. I don't
Okay.
really spend too much time
Mm,
interacting really as
mhm,
much. So
okay.
not really.
Not yet. Okay.
Yeah.
But you certainly have enough cultural beliefs within your own culture. Yeah,
Yes.
that's awesome. Mariana, what about you? How do you, oh, you have no voice. Okay. Okay. Stephanie.
Hi.
Hi. What have you learned about cultural competence and how are you working towards being culturally competent?
I think I learned a lot because at my work we got like different people with different culture. I remember that man, he was an Indian. We'd be standing with the head down. Like every time we like talking to him, he said, "No, I need to talk to my mom and dad before I do this or I do that." So we
Yep.
didn't understand because he was a grown-up man. I said, "Okay." And then one Sunday they got visitation. And then I saw his mom and his dad, and he was doing the same thing too, heads down, and then he was talking. So I said, "Oh, now I
Interesting.
understand why he was doing that."
Interesting.
Yeah.
Yeah. And what do you, I mean, let's say you're working with a family from a different culture and you don't have that knowledge. It's brand new to you. You don't understand some of the manifestations or actions. What do you do? What's a
I mean,
simple
asking
ask?
question. Yeah.
Ask. People love to talk about their cultures and why they do certain things and why they
Yeah.
don't do certain things and why it's not okay
Mm-hmm.
if you do something this way.
Mm-hmm.
That's how lots of cultural knowledge is obtained by asking, right? Yeah, that's
Yes.
a great example. That's an awesome
Thank
example.
you.
Kia, what about you?
I don't have any experience.
You haven't worked with any other cultures ever?
No,
I can't see your face. I can only see your forehead.
no.
Okay. So let's assume that you went to work tomorrow and were working with a family of a different culture and you didn't understand what was going on or understand their mannerisms or their language or why they were doing certain things. What would be some good ways for you to obtain knowledge and be able to implement their values and beliefs?
Um, Honestly, I don't know. I guess I would probably do like research to find out.
Okay. What if you didn't have time to research? You're already on duty and you walk into this room and all these things are going on and you're clueless and what do you do?
I don't know. I guess I had to figure it out. I don't know.
Well, you talk to the patient, right? You talk to the family. Here's how we see the healthcare plan going forward. What would you like to add to that based on your cultural beliefs and attitudes, right? How does this sound?
Mm-hmm.
Does that make sense?
Mm-hmm.
Yeah. Danya, what about you?
Hi,
Hey.
I used to work at an urgent care. We had a lot of Arabics come into that specific area because it was in the northeast of Philadelphia.
Okay.
There was times that we had people like just come up to the front desk and will ask if there's a male or female doctor. If there wasn't a female doctor and they had their wife being seen, they
Yeah.
wouldn't be seen at all. Even if we had other female staff on like there, they wouldn't see them. Even if the doctor was in the room with the female staff to help them feel more comfortable,
Mhm.
they wouldn't allow it because it still wasn't a female doctor. There was other times that like just the male will be speaking for his wife,
Mhm.
and even if there was a language barrier and we had someone like interpret for us,
Uh-huh.
it will still be the male speaking for them.
Mhm.
Like the female will never speak, it will always be the males.
Right. And initially, did that make you feel uncomfortable? And as you gained a
At
better
first, like as Kristen said earlier, it did feel like it was a controlling thing. But then as I seen like multiple people coming in and doing it, I realized it was probably just their culture.
Exactly. That's a fantastic example. At first, you're a bit taken back, but then you understand that it's a different culture with different values, beliefs, attitudes, practices. And that's why I've been continuously saying through this term is we have to take those cultures and try and incorporate as much as we can into the plan. But there are certain things we may not be able to do. So Danya, how did that how'd that get resolved with the female doctor? They had to wait for a female doctor.
Well, the urgent care I worked at, we usually didn't have doctors switch out, so they will end up going to a different facility.
So they would actually leave.
Yep.
Yep. Yeah. Great. Wow. Yep. Janae, how about you?
Hi.
Hi.
I have zero experience because I was straight out of high school coming into the program.
Okay.
So I'm learning through
Great.
classes.
All right. So what do you have med surg?
Mm-hmm.
Okay, so you're doing your med surg clinical, right?
Mm-hmm.
And you go into a room and you're taking care of a client that is speaking a language that you have no clue.
Mm-hmm.
Right? And you're asking questions about how you're feeling, whatever, and they're looking at you like you have 5 heads, right? Because they probably don't even understand you. Where do you start? Where do you start? Because that will happen. I promise you, that will happen. Where does Janae? Let's open it up. Where does Janae start? Where does she start? And she's totally like, oh my God, what's going on here? Nobody's speaking the language. Nobody even understands what I'm asking, what I'm trying to do, whatever. Where does she start?
Do you want me to answer or
No, anybody?
Maybe bringing somebody in with her, asking her nurse or.
First, you got to establish what culture we're even talking about, right? So where does Janae start? Maybe asking the previous nurse who took care of them? What
I would say
information?
look in the charts, right?
Sure. Yeah. Because there's no way you're going to make any progress until you get some more information, right? I mean, that's a good one. Janae says, I don't have any experience. Great. Okay, that's fine. But she's going to be in a position where she's going to be taking care of a client or a family that's a different culture from hers. That has different values and beliefs. So yeah, let's go back and look at the chart. Maybe talk to the previous shift that have taken care of these. Let's say they're coming up from the ER. What did the ER figure out? Right? Maybe they got admitted through the ER. They got admitted through, I don't know, urgent care. You're going to have to do some research. What culture is this? What's been going on so far? How are you communicating? Right? Are there family members there to help you? So Janae, it's something to ponder, right? Joy. Whoops. Joy, give me
yes.
Go ahead.
Being I'm gonna use my workplace.
Okay.
In my situation, I was able, being a Muslim, I was able to educate my coworkers on certain behaviors and why people did certain things. The Muslim young man that we have, they didn't understand why he always had to drink and eat with his right hand. And Islam, people didn't know that, but eating or drinking with your left hand is is considered like dirty. Your right hand is always your clean hand. So when he had a little injury with his hand and I was giving him a drink, they like, why don't you just give it to him? His other hand work. I'm like, no, but that's not what we do. You know, he is brought up to whereas in his religion, our religion, that you drink and eat with your right hand. Also, like another person mentioned with clothes, getting dressed and bathed, like you can't have no women taking care of the men and the men taking care of the women. And their thing was if it was short of staff, then they just have to accept what they accept. And I'm like, no, you don't just, you know, do it like that. It's a respect thing. So, you know.
Yeah, so
In that
this
case,
is so this is a little bit different than what you guys have been giving examples of how you learn about other cultures. What Joy is telling us is she's the one teaching her peers, right? She's the one teaching her peers. So a nurse comes out of the room and says, hey, I don't understand why this is going on. Joy goes, I'll tell you exactly why it's going on. This is the culture. So a whole different perspective of Joy using her expertise with her culture in teaching her team members how to care for a culturally different family. Excellent. Oh, that's awesome. That's awesome. That's great. Rashima, what about you?
I've taken care of a patient before that requested females only, and like the male was able to do stuff, but only like going to get a pitcher of water or something like that. No direct care.
Okay.
And assignments did have to be moved around for that to happen on the floor. Although we had like all of males, like one female and a male and two males, they were already assigned to a group of patients. We just switched or we switched out just that patient with another patient of another, you know, so that that patient receives what she needs to go along with her religion.
Right. So you had to make accommodations to accommodate that religion. Excellent example. Springsea, what experiences have you had? Excellent example, Rashima. Thank you. Springsea, what about you?
I haven't had any, but being as that I am in a Haitian culture descent, I've worked with so many, but I've always just understood that a lot of cultures need their privacies. So I haven't really ran into any cultural beliefs or
Issues yet? Okay.
Yeah.
And so if you did, what do? We talk to the client, talk to the patient, tell me about your culture, tell me what are your beliefs? Well, how can we incorporate your beliefs into your health plan, your plan of care, right?
Right.
Because it's gonna come up. It's gonna come up for everybody, and it's gonna come up all the time.
Right.
Right. It's just
Right.
This is to everybody. That's just a fact. And the
Right.
diverse
And people are known to correct you when you try to kind of like suggest something. They're like, no, we don't do it this way. So I always believe that somebody will always correct you and say, no, that's not how one is done. This is done.
Sure. Or help educate me on how you would like it done. Right?
Right.
I mean, let's see. I've been in nursing 40 years. I'm still working on cultural competence, right?
Right.
I mean, it just wasn't as big of a not issue. It just wasn't as big of a thing 40 years ago, right? But as nursing has evolved, whether it's in the hospital, the schools, working with different kids from different cultures, parents from different cultures, this is something that is evolving through your whole nursing career. Does that make sense? It's one of the most important aspects in the foundation of our practice is we are going to be caring for dozens and dozens and dozens of different cultures. Right? So it makes sense to start thinking about that rather than bucking it and having your own, if you have your own prejudices, biases, whatever, those have to be sorted out. And let's say you can't care. You can't because of your beliefs, whatever. You can't abandon, right? You have to make sure that that client is covered, right? Brittany, what about you?
I could say my time working in a nursing home, and you don't get to see Asians as often, or Chinese people as often in the nursing home, because they normally stay at home with their family. The one time I did have an Asian or person in the nursing home, his family tended to him, like they made sure that he ate food from home, and he had fresh fruit and his green tea. He was on hospice, so they made sure that it was someone there always to bring him fresh cooked, home cooked food.
Yeah. Right. We heard that similar story with somebody else talking about working with an Asian family. So certain cultures have certain beliefs, right? Certain cultures have certain values. They have certain practices. They have certain food preparation. They have certain caretakers. And like I've said a few times, we have to do our best to incorporate cultures into the plan of care. We have to, right? Seek out help if there are barriers. Maybe the barrier is you and your beliefs, or maybe it's a language barrier. Maybe it's a comprehension. Maybe they can't read in the English language. We talked about that with education, trying to prepare as many tools for them in their native language, right? And that's why I spent some extra time on this today, because look at all the experiences you've already had. And there's going to be many more to come. So good job. No, I appreciate everybody sharing. Okay, I'm going to jump to if you want to pull out your study guides and take notes, I'm looking at a different screen. So if I keep looking up, I'm looking at a different screen. Okay, so your study guide. Okay, so the intent is that you have gained the knowledge over the last couple of weeks with all the concepts from week 7, week 8, and week 9. Okay, you have weekly notes that are very detailed. Okay, that go through each of those concepts. So now it's time to put down, to identify which knowledge from those concepts is going to be critical to understanding the concepts. So, for example, week 7, we have infectious disease prevention and control, HIV, tuberculosis, STDs, and bioterrorism and disaster. I'm going to go through my notes and pull out what do we need to know? What do we need to know about infectious diseases? Why is infectious communicable disease, infectious disease, and control in the community so important? Talk about that.
Depending on what atmosphere they're in, like it could be a homeless shelter where they're like spreading communicable diseases, and like migrant workers who share like a household, and you know, they bring things in and they all
Maybe
get
at risk
sick,
for
stuff like
TB.
that.
So infectious diseases, communicable diseases play a huge part in the health of a community, right? Look what happened during the pandemic. Okay. One of the first things to be aware of with infectious and communicable diseases is there's a reporting system. The CDC has a reporting system, right? Certain communicable infectious diseases need to be reported. There's a federal website that lists everything that needs to be reported. That goes all the way down to the state and local levels, and they can add. When I was in school nursing, we had an infectious communicable disease book that came from our local health department that listed out all the all the potential infectious diseases, communicable diseases that need to be reported. Pertussis, hepatitis, HIV, any kind of measles, rubella, anything, right? And remember, it's not only me and the schools that need to report, doctors' offices need to report, emergency departments need to report, urgent care needs to report. Everybody has to follow the same guidelines, right? So that's first and foremost. Okay. One of the things we talk about with infectious disease prevention and control is the epidemiological triangle. Tell me about that. It has 3 tiers to it. What are they? Mariana, you try to talk?
Host, agent, and environment.
Yep. Okay. So the agent, what's the agent? What is that?
The disease.
The bacteria? Is it viral, chemical, fungal? There has to be something going around. Influenza? COVID? Exposure to a gas? You have to have an agent, right? That agent then infects a host. What's the host? That's us, right? What kinds of things do we need to assess in the host to see how maybe ill they'll get or maybe less ill? What kinds of things would the host, us, that we present with, which may give us an indication on how we do? Let's talk about influenza. Influenza is the agent. What if the host is maybe had a flu shot? Might they fare a little bit better?
Might be shorter.
Maybe shorter. What if the host is elderly? Might they have a more difficult time? Okay, so there are factors, the host has factors that could influence, exactly. Mariana said, factors that increase resistance. Okay, take COVID as an agent. Take a host that is a young, healthy teenager versus an elderly person, maybe in a nursing home. Is that young, healthy teenager going to probably fare better with COVID than the elderly? Okay. Then throw in the environment. I already kind of said nursing home, but how does the environment play a role in it? Let's say people work in environments that are extreme hot or extreme cold or extremely like a nursing home or assisted living where things get passed around quickly. The environment makes a difference. So between those 3, you have to have an agent, a host, and obviously an environment. Many, many scenarios can be established by those 3. Does that make sense? And that's what makes up the epidemiological triangle. You have to have an agent that infects the host. The host has many factors: healthy, non-healthy, obese, non-obese, comorbidities, no comorbidities, and then your environment. Is your environment conducive to being more at risk? Okay. Next is your HIV, TB, and sexually transmitted diseases. Here's what we need to know. With your HIV, how is HIV spread?
Sexual contact.
Sexual contact.
What else?
Blood.
What else?
Needles, yeah.
Can it be spread through breast milk?
Yes.
Sure, absolutely. Okay. What do I want you to know about HIV testing? Why do we go back and test in 3 months again?
Because isn't it like sometimes it won't pop up or something like that?
That serology test may not be positive. right off the bat. It may take up to 3 weeks for the antibodies to show up, right? Let's talk about HIV infected people who in a correctional facility. Is that important? What's the risk there? What's the risk?
Transmitting it to others throughout the place.
What? Right. Close quarters, right? Lots of people, close quarters, much higher risk of transmission, kind of like the migrants living in the busy or crowded housing. Got to think of the correctional facilities as well. TB. What do you want to know about TB? How is TB spread?
Airborne.
Pardon me?
TB, you said how, like airborne?
Yep. How is it transmitted? Airborne droplets, right? How do you screen? How do you screen for TB?
Get the
A TB skin test.
Get a test, yeah.
Skin test
Yeah.
or test X-ray?
Well, what do you do first? What if you have a positive TB skin test? Then what?
Chest X-ray.
Chest X-ray. Yeah. And let's say you end up being positive for TB. There's a medication regimen you need to be on, correct? And those patients need to be followed by the public health department routinely to make sure they're taking their medication. It's not an option. The few STDs that you need to know about are, we need to know if they're viral or bacterial. Okay. Chlamydia.
Bacterial.
What is, yeah, bacterial or viral?
Bacterial, because you can take an antibiotic for it.
How is it spread?
Sexually through saliva, right?
Huh?
Through sexual contact,
Sexual
right?
contact. Right. So since it's bacterial, can we treat it with, well, we have to think about with these bacterial or viral. Obviously, if it's bacterial, it can be treated. What if it's viral? What do you do? Symptom management, right?
Management.
Symptom management. That's all you can do. Right? So you need to go back to your week 7 notes where we talk about gonorrhea, syphilis, and then also in there is your herpes simplex. Is herpes bacterial or viral?
Viral.
So what do you do?
Manage symptoms.
Manage symptoms. Contagious?
Yes.
Always contagious. Okay, and then HPV. What's HPV?
It's not something that causes like
Human
cervical cancer or something.
papillomavirus.
Yeah,
Well,
human papillomavirus.
Okay, and what is that? Bacterial or viral?
Bacterial.
Viral.
Is it viral? Because they offer a vaccine for it. So is it viral?
I think it's viral.
They have a vaccine for it, right? That's what I want you to know about HPV. There is a vaccine for it, right? 3 doses are recommended, safe and effective. Okay. I missed something here on infectious disease and control. We talked about, okay, hepatitis. That's under infectious disease and control. What's the difference between smallpox and varicella? How do you tell the difference between smallpox and chickenpox? One distinct difference.
One is just like in certain areas, right?
Yeah, keep going. What are the areas?
Hands,
And?
mouth.
Nope.
No.
Come on, somebody
know
The
that
needs
area.
to
palm
know
of the
these.
hand, the palm of the hand, and the feet for the small pox, and then the chicken pox is like up here, like
Yep.
anyway.
So soles of the feet and palms of the hands. Right? That's classic for That's how you tell the difference between chickenpox and smallpox. That's where you're going to see smallpox. Palms of the hands, soles of the feet. You're not going to see it. You're not going to see that with chickenpox. Hepatitis, viral, bacterial.
Viral.
Bacteria, which one? Can they be
You
both?
you tell me. What's hepatitis A?
I know B is like a STD,
B is
right?
bloodborne. B is bloodborne. What's A?
Okay. I'm not sure what A
They're
is.
all
Y'all help me
viral.
out.
Okay,
They're
hepatitis
all
A
viral.
is the fecal oral contact, right? B is bloodborne. Risk, IV drug abusers, people with other STDs, multiple sex partners. Hepatitis C is also bloodborne. Okay, but with the difference between hepatitis C is that the large majority develop a lifelong infection. C is pretty chronic.
And you say they're all viral? All three of them are
Yeah,
viral?
viral.
Okay.
So what is it? A lifetime of symptom management, right? Okay, so hepatitis, smallpox. We covered HIV, herpes, we covered HPV. Okay, what are the two kinds of disasters? I'm kind of doing a review with you now, even though I'm going to be doing pretty much the same thing in an hour. But I don't know how many people can attend the live review, so that's why I'm.
Bioterrorism is one, right?
What?
There is natural and man-made.
Man-made.
And
Okay,
man-made. There you go.
Okay, so give me some examples of natural.
Earthquake.
Hurricane, earthquake.
Hurricane.
Tornado.
Man-made would be
Tornado,
fire.
volcano eruption, stuff
Yep.
like that.
Yep. And then what a man-made?
Fire.
Fire. Pollution.
Mhm.
Water pollution, air pollution, wars. Right?
Chemical warfare, stuff like that.
Exactly. Nurses are expected to participate in any impact phase of a disaster. Okay, we have to be prepared to do the preparation phase. Remember, we talked about in our notes, part of the preparation or preparedness phase is helping families prepare that kit. Remember that kit? That's our preparedness. What do we want that kit to include? What is it? There's 5 things. What do we want in that kit? Well, not in the kit, but 5 things we need to know. How much food? Guys, you need to go back to your notes and read that. How much food do we need 3 days? Right? 3 days. Inspected every 6 months for any kind of expired items, right? What does everybody need to know? 2 things.
The safest route and
Nope. Yes, but that's not part of what I'm talking about here. Everybody needs to know where the
Where
kit's
the
located.
kids are located.
And what
and
else?
where to turn off the utilities.
How to turn off utilities. You're going to get asked about that. All right, so make sure you have an understanding of that preparedness. Okay, and then the impact stage. During the impact stage, you could be assigned anywhere. You could be doing triage. You could be assigned to, what are they called? Shelters. You could be assigned to make sure people are getting their medication, people are getting their supplies. You could be out there doing direct triage. You could be transporting. And then you're also expected to be able to perform in the recovery stage, how to get people back on their feet. Right? So we are expected to function. Okay. Couple things to consider. How do we know that water is safe to drink again after a disaster? That's in your notes, but let's review it. 4 things. Okay. Boiling for 3 to 5 minutes. Bleach, 1 ml per gallon. right? Remember this from your notes? And that has to stand for 30 minutes. And then the water needs to be drained from your water heaters. It's contaminated water. So if you're instructing, let's say you're part of the disaster team and people are asking you, when is our water safe to drink? Do you know? You have to be able to tell them what needs to happen. And a couple things about chemical spills. This is the bioterrorism part of the lecture. You have different chemical spills. Okay. First of all, what would you use to remove clothing for a chemical spill? Your hands? What do you use?
Gloves.
What?
Gloves.
Look at Mariana tongs. Okay, that's in your notes. You got to know that. Your hands. Let's say your hands and you have gloves on. It's a chemical spill. It burns right through your gloves. Tongs. Okay, so we have 3 different kinds of agents that we talk about in this section. One is vesicant agents. It's called vesicant. It's in your notes. Nerve agents, vesicant agents, nerve agents, blood agents. Okay, an example of a vesicant agent. This is right in your notes, guys. Mustard. What we need to know is what systems does it affect? So your vesicant agents, which would be an example, would be a mustard gas. They affect your eyes, your skin, and your respiratory. Okay, let's say you have a nerve agent. Let's say such as sarin. Okay, that's straight up extreme respiratory effects. Okay, this is right from your notes. Let's say you have blood agents such as, say, a cyanide. Okay, that is skin and respiratory. So I just need you to know those 3. What systems are most affected by those 3? Okay. Moving into week 8, home care. All right, so there's 2 main points about home care. What are they? Go ahead, you tell me what they are. Where are you caring for the client? In home care, where are you caring for the client?
In the home.
Home.
In the home. And the other main point to remember about home care is you're caring for the individualized client. Right? Individualized client and care is in the home. Okay. Case management. Nurses are often in the role of a case manager. What is case manager? What does a case manager do? What is
Someone who
You're the
takes care,
advocator.
advocate for the patient after when they're about to leave or upon discharge, like discharge planning, stuff like that. Like if they need equipment to go home, if they need therapy, stuff like that.
coordinator of care? Right? Coordinator of care of the complex clients, right? Not everybody needs a case manager. Let's take an example of an elderly person that's had a bypass surgery. All right, and they're getting ready to go home. They have plenty of family. All their appointments are scheduled. They have transportation to get to their cardiac rehab. They have people living in the home that can cook. And they need a few things. Family can help set up the oxygen, right? By calling the company, getting that set up. That client does not need a case manager. What about the same client who has no family? They're going home to no one. They have no transportation. They have no resources. That's the kind of client you would want to case manage, right? It'd be nice if everybody had a case manager, but that's just not realistic. Okay. So Sorry, guys, sorry. I'm pooping out here. What else? Different ways to communicate. Case manager may need to communicate in many different ways. There's a difference. I want you to know the difference between these four. These are right in your notes. What's the difference between collaborating, cooperation, compromising, and assertiveness? 4 different ways to communicate. They each have a different definition. Let's go back to your notes and look at that. Be able to identify that if you're given a scenario and here's what the nurse is saying to the client or the family or the home health agency, and she's saying this, what is she doing? Is she collaborating? Is she cooperating? Is she compromising? Okay. Okay. All right. What else? Let's move. Well, we just covered human abuse and violence, cultural influences in nursing. So that should all be fresh in your mind. So as you're thinking about these 3 weeks of concepts, go back and review your weekly notes. Okay. And think about what we learned during class time and then start to apply it into critical judgment, critical thinking of scenarios, actual scenarios. Okay. So if you were caring for a client that was a victim of intimate partner violence or domestic abuse, if you were caring for a client that had an attempted suicide, if you were caring for a client from a different culture, these are scenario-based questions, right? Using your best clinical judgment based on the knowledge you've learned from these concepts, right? That's the way the other 2 exams have been. That's the way this exam is. That's the way your HESI's going to be. Okay. Questions? Helpful? Okay. Okay, does anybody have any questions? That's it for me. I know we have another 15 minutes, but I'm going to give you 15 minutes of the gift of time because I'm going to break out in coughing attacks here. I can feel it coming on. Is that all right? What are you going to do with, I have an idea. What are you going to do with your 15 minutes? Work on your study guide. Okay? Take these 15 minutes and work on your study guide. Make sure you pull out your 3 weeks of notes, weeks 7, 8, and 9. If you need to go back to your readings to supplement that, do that. And if you guys don't test till next Tuesday, if anybody needs any help, after you've done your due diligence and prepared the best you can for the exam, and you still need help with some of the concepts, or you're just not getting it or understanding it, or need to talk through them, schedule time with me next Monday. And I'll meet with you guys and help you out with that, okay? I want everybody to do good on this exam because I would rather the pressure be off going into HESI, okay? The better we can do on this exam, I mean, this class overall is doing really well, so, but the better you can do on this exam, the less amount of pressure you have with your HESI, right? Okay. All right, well, I hope you guys have a good rest of the week. Oh, thanks. Thanks, Joy.
Feel better. Yeah,
Sorry for
feel
all the
better.
interruptions of coughing and stuff. But you guys have a good rest of the week. You know where to find me. Please reach out if you need anything, okay?
Okay, thank you.
You're welcome. You're welcome.
Bye.